Welcome, everyone. My name is Tristan Claridge, and I'm the convener of this webinar series for the International Social Capital Association. The association's mission is to advance the research and application of the social capital concept. And if it's something you're interested in, you might be interested in becoming a member of the association, and information is available on our website. In this session, we welcome Lauren Bigger for a presentation titled The Relationship Between Social Capital and Health Outcomes in a Southern Rural Population. Lauren is a doctoral candidate in the Department of Behavioural, Social and Health Education Sciences in the Rollin School of Public Education at Emory University. Her primary research interests are in community-based approaches to understanding and addressing health inequalities, including assessing how outer contextual factors such as social capital influence health outcomes and the implementation of health-related policy, systems and environmental changes. We're delighted you've agreed to give this webinar, Lauren. Welcome, and over to you for the presentation.
Yeah, thanks so much, Tristan. I'm really honored to be here. And it's always exciting as, a researcher, you send these papers out into the world, and it's so much fun to be able to talk about them and share the work that the team I'm a part of has been doing. So here, just to kind of give you a sense of what this presentation is based off. It's based off a published paper that was published in the Journal of Rural Health under the same title, and you can see the team there that I'm a part of. And of course, just want to thank the members. You'll learn about it in a little bit about the Two Georgias Initiative, the management team, and the members of those coalitions. This project was funded through a grant from the Healthcare Georgia Foundation, and so I absolutely want to give them credit for that. This will kind of give you a sense of where I'm headed over the next little bit. I'll start just by doing an introduction. I think it's so important to really understand who is doing the research, what's the research group's kind of intents and our perspectives on health and research. So I'll give you a little bit of background on that. And then instead of kind of going through the order of how you would normally read a paper, I want to give you a little bit more background and kind of insight into really how we came about to the research questions that we even arrived at. So we'll delve into really the population and the parent study that this work is coming from. And then I'll go into how we've conceptualized social capital, the methods, the results, what surprised us, and hopefully we can end with a conversation about how my research kind of intersects with yours, what questions the research team I'm a part of we still have about social capital, and maybe what questions you have as well. So just to start off, this research is coming out of Emory University, based where I am in Atlanta, Georgia, in the Rollins School of Public Health. And we have a prevention center. So the CDC, Centers of Disease Control, is supported and directs a national network of academic centers called Prevention Research Centers. And they're based across the US in schools of public health or medical schools that do have a focus on preventative medicine. And these are kind of some of our core tenets at Emory. We conduct research and evaluation studies really seeking to intervene on social and physical environments that affect tobacco use, physical activity, and nutrition. So really these risk factors for chronic disease outcomes, as well as obesity and in particular cancer screening. So we're not just looking to kind of develop the information, but looking to develop it in a way that's actionable for communities. And to that point, the research is really developed in collaboration with community partners, specifically in rural Southwest Georgia. So I think it was about 2 weeks ago now, we just had actually a meeting with our community advisory board celebrating 20 years of partnership, where we're working with them to kind of develop the questions, develop the initiatives, and really focus on their needs and their communities and how we as an academic group can partner with them. We also conduct trainings, offering small grants programs, really seeking to translate the research into practice as we seek to strengthen chronic disease prevention efforts and promote community involvement in prevention research broadly. And so I think it's just helpful to have this kind of perspective going into this paper, that when we do research, we're really looking to do it in a way where it's community engaged, focuses on gleaning information that can really be practical for health promotion activities. And so kind of diving into the population and the parent study, excuse me, I'm fighting a little bit of a cold today, of where this research is coming from. So this idea in Georgia, to orient you for those who aren't in the US, Georgia is in the southeast portion of the US. And there's this idea that there's essentially two Georgias, that there is kind of a few urban centers, Atlanta in particular, and then a lot of the rest of Georgia really is extremely rural. And so Georgia kind of functions often in two different ways. And in terms of when we look at health outcomes, there really is this rural-urban health gap. So we look at things both as morbidities and mortalities of rural and urban areas. There really is evidence of an excess of things like heart disease, cancer, injury, both like motor vehicles as well as opioid overdoses, chronic lower respiratory disease, and stroke. And so it's not just that there's a difference, but it's inequitable. There's more than there should be. And some of these reasons for this are limited access to healthcare. Obviously, just living in a rural area, you're farther from being able to access a health center, limited transportation to be able to get there, struggles gaining health insurance. Second, there is limited access to healthy food. So supermarkets, again, are far and few between, often in some of these rural communities, and healthy food options can be limited. Thirdly, there are some health behaviors such as chronic disease risk factors that I mentioned. Our Prevention Research Center focuses on like smoking, physical inactivity, and we do often see higher rates of those in rural areas. And then lastly, just the demographics of recognizing that rural populations in general tend to be older, lower income, and have lower education, which just increases some of the risk for some of these chronic conditions. And so with all that in mind, this initiative called Two Georgias Initiative was developed, and it was a 5-year initiative from 2016 to 2022, and it was a placemaking grant. And so the idea was really, how can community coalitions in rural Georgia, and the map here shows, just for reference, Atlanta is the star in the center, just where people may be more familiar with that city, and then the highlighted counties are the counties across Georgia that participated in this initiative. And so the goal really was to support community coalitions across rural Georgia as they thought to advance health equity through really capacity building, developing policies, systems, environmental changes, and programmatic changes in their community to address their specific localized concerns. And just to give you a sense also of really what were these coalitions working on, what were their projects, they were really seeking to address some of these things that I pointed out already of what can kind of cause and lead to these health disparities. So they worked on issues around how can we improve access to healthy eating? How can we improve access to physical activity spaces? Whether that's developing lighting across a bike lane, so suddenly this is more accessible on a sidewalk. Improving access to healthcare, focus on education and literacy, economic development initiatives, housing initiatives, transportation initiatives, and substance use prevention. So it really was this whole wide range of looking at what are some of these social determinants, kind of these underlying factors that are going to lead to inequitable health conditions in their communities. And they went after these efforts. And then part of this study, Emory, the Prevention Research Center, we served as the external evaluators for this study. So really looking across these 11 coalitions. And part of that was conducting a population level survey, just to get a sense of what is happening in these rural communities. Can we get a better sense across these domains? Because often the data that we have when it's just looking at a US or country level or even state level sample isn't going to give us enough of that nuanced detail that we need, particularly for a rural area. And so this was an opportunity for our group to get some of that data and better understand the populations that we were working with. And so this survey included factors along the lines that really did match up with the work that the coalitions were doing. So food access and food security, healthy eating, physical activity, healthcare access and utilization, social capital, health status and quality of life, well-being, and then of course, just general demographics to get a sense of the population. And so this was a cross-sectional study, and that's what the analysis that I'll present is based upon. So it was a population-based survey. It was a baseline survey relatively towards the start of the initiative. And we used commercial mailing lists. So they were randomly selected residential mailing addresses that provided the sampling frame. This was determined to be non-research. So Emory's IRB determined that the study was really part of a program evaluation, and so it didn't require IRB approval. And then for this study specifically, 5,558 surveys were mailed out over this time period. And we provided things like follow-up postcards when someone didn't initially respond to that survey. The survey itself took about 15 minutes for participants to complete, and those who returned the survey with a stamped envelope received a $15 gift card as compensation for their time. We had a response rate of about 24%, which was pretty much in the range of what we were expecting. Again, they didn't have necessarily a relationship with the institution that was sending this out. This was really just starting from a random sample of a mailing list. And we considered complete for this analysis to be when those surveys had 50% or more of the questions answered. And now I'll kind of delve into how we conceptualize social capital from this survey. So when we, again, are kind of starting from understanding that there are these disparate health outcomes, we kind of naturally want to backtrack and say, okay, what are the causes of that? What can we glean from that? What are the intervention points? Where, yeah, those inflection points to kind of shift things. So this model is by Warnicki, published in 2008, and their colleagues. And recognizing that, so here, I'll kind of give you to orient to this model. So on the right, you have the disparate health outcomes. And then on the left, this shows you from the proximal factors, the factors that are going to be closer to an individual, all the way up to the distal factors. So on the bottom, you have things like the biologic and genetic pathways that are going to contribute to health outcomes. And then going up into these individual demographic and risk factors, perhaps individual demographics, like I discussed, population broadly just being older and the inherent kind of risk factors with disease that come along with that. And then in the middle, we have our social and physical context. So this is really the environment that people are living in. What's the pollution levels? What does transit access look like? And then we get into the elements around social capital, those social relationships. If people have social support, are they isolated? What's their social influence? And then more concretely, collective efficacy, social capital, kind of falling into the social context bucket. And then higher up, this really broad fundamental causes or more social determinants of health, the institutional context, social conditions along the lines of poverty, culture, norms in the environment and the society that they're operating in. And so here, kind of identifying that social context is here and recognizing that what this model helps us understand is that it's really key to understanding and addressing these population level health disparities. And so I think this is an excellent model that really helps us to process some of these, understand how some of these complex processes interact, and again, identify those points of intervention. So it's really positing that these intermediate determinants are what helps to link environmental factors and individual demographics and risk factors. And so this was important for us as we considered kind of our analysis and why we were pursuing social capital as we sought to understand the health disparities in these communities. And so then how are we conceptualizing social capital? Obviously, there are numerous ways, which makes it, I think, both an interesting construct and a complicated construct to study, as I'm sure you are all familiar with. And so I wanted to be clear about the approach that we took and why we took it. So we looked at it really fundamentally as an element of social cohesion. We considered 5 domains in the broad population level survey: trust in others, support from others or reciprocity, diversity of interaction with others, civic engagement, and voting behavior. And then specifically for this analysis, we focused on the 3 latter items. And we did this particularly in the relevance to the work of the Two Georges initiative. These definitions are aligned both with Putnam and Engber's in their 2017 paper, Engber's 2017 paper, and how those 2 groups have conceptualized social capital. Engber's kind of calls for these primary 5 types of social capital domains, which again aligned with a lot of the work that we were doing in these communities. And we drew our specific questions from the social capital benchmark survey. And so as I go through these next ones, just wanted to be, again, really, really explicit about the measures that we were using, why we use those. And I think it's also important and helpful for me in my work to be kind of reflective at this point. So I would just encourage you that as I go through these questions to just kind of consider how do you rate in this? If you were filling out this survey, what would be your score? Just knowing that, or I personally at least don't believe that science is ever truly objective, that we're all coming in with our own lenses, our own set of experiences, how we've engaged in communities, how we've experienced our own health. And so I think it's important to recognize that what my social capital is going to naturally influence the kind of questions that I ask in science, and potentially as well of how I interpret those. And so I think it's important to have a team to operate in a team science manner where we're including others and kind of conversing around this topic of how are we interpreting these things. So just as I go through, if you'd like, just kind of think to yourself of how you would rate on this. So our first one is diversity of interaction. And so we ask people to think about how often do you talk or spend time with different groups of people? This may be in person, over the phone, through the internet, or social media. And so they were given the options to either say, not at all, I don't engage that way, or very often. So again, we were looking at how diverse are your interactions in terms of people in general, your friends and family, people that live near you, people from a different racial or ethnic group than your own, people with different political views than your own, people from a different religion than your own, people with more or less education than you, and people who spend more or a lot less money than you. So really getting at this concept of, are you operating in a space, in a social space, where you have people who are just very similar to you and you're kind of in a single perspective? Or are you operating in ways where you have relationships with people who view things very differently? And then the next one is around civic engagement. And so this one obviously was particularly important with the Two Georges initiative, where we're looking to, grow community capacity, grow that kind of sense of engagement, and really look at what people's agency and their ability to affect change in their own communities. And so this was having individuals reflect over the past 12 months. Did you get together with people from your community to fix a problem or do something positive for your community? Attend any public meeting in which there was a discussion of a local issue? Contact or visit a public official at any level of government to express your opinion? Attend a political meeting or event? Decide whether or not to buy products or services based on the social or political values that that company provides them? Belong to any groups, organizations, or associations? Serve as an officer or served on a committee of any local club or organization? Attend any club or organizational meeting? Volunteer for a group, organization, or association, or attend a religious service at least once per month. And this was either just a yes, no response. And then for each of these, we created kind of summary scores for each of these domains. And then finally, we had a voting behaviors domain as well, asking about voting habits. And this was very simply, did you vote in any of the recent elections? The local elections, such as mayor or school board, and obviously that could vary by community. The midterm election or a presidential election, yes, no. And then we consider the don't knows to be no, because obviously if you don't even know if you engaged in a recent election, that kind of represents a lack of engagement in a political landscape in general. And then our outcomes were health and well-being, and here's a sense of how we conceptualize those. So we had three different questions, three different outcomes here. And this first one is from a broad scale, but we just chose the single question. We found that to be pretty representative as well of the full scale. And so it was thinking about your own life and personal circumstances in general. How satisfied are you with your life as a whole, ranging from not satisfied to completely satisfied at 10. And then the next two questions really get at health status and quality of life. So a little bit more specific of a health metric. Would you say that in general your health is, and then ranging from excellent down to poor, and then thinking about your physical health, which includes physical illness and injury, for how many days during the past 30 days was your physical health not good? And so those were our health outcome measures. And so when we look at the literature seeking, how are these two concepts potentially connected? Obviously, we use the Wernicke model that shows that there is this relationship between these two. There is an impact, but what are those pathways between which social capital may impact health? And the literature shows three primary pathways when we reviewed it. The first is social contagion. So this idea that ideas spread in tight-knit social networks. There can be this diffusion of information and really an establishment of behavioral and social norms. And then that can translate right into health behavior. So if I'm saying, oh, we walk all the time, we just walk to the store and this is what we do, we're increasing our physical activity, then maybe that's a social norm in my community. The second is informal social control. And so this is the idea that there's kind of an informal policing or suppression of undesirable behaviors. So this could be group members essentially controlling each other's diet and exercise for something like chronic disease prevention. So if you have someone to say, hey, no, we're not gonna drink that soda, we're only doing water today, in a group setting where that again is just kind of the norm and there's that influence towards that could positively be influencing your health behaviors. And then third is this idea around collective efficacy, that communities and social groups have the ability to mobilize, to solve, or prevent problems. So you can see this is quite closely tied to the Two Georges initiative and this idea of a community, even a large county, can come and collectively mobilize to change their own health outcomes. So this could also be down to a smaller level, though, of collectively providing access to healthcare. Your neighbor says, oh, I'm older, I'm not able to drive anymore, but I have this healthcare appointment. If they have that strong social network, they may have someone able to simply drive them to that appointment, kind of solving that problem for them. And then social advocacy, as I touched on as well. And so I think we kind of, take a step back then, and what are these questions that we have around social capital? When we reviewed the literature, overall, the literature really does point to a link between social capital and health. But what we found is that the findings in general in the literature are inconsistent. Are there questions around measurement issues, different outcomes that we're potentially selecting? And then our team was also interested in, are we ignoring potentially the dark side of social capital? That we say that it has this ability to influence us towards positive behaviors, but who's to say that our communities also are influencing us towards negative health behaviors? And it also, if the community has social capital, when we're thinking about how are we defining a community and perhaps who is being excluded from assessing certain social resources. So when we look at a broader community like a county, are there individuals or groups of people who might possibly be excluded from that social capital in a tighter social network? And supplementary to this, we were interested in really, particularly in the US setting, do the benefits of social capital extend across racial groups in the US? So particularly with this, there are a few studies that do link social capital, health, and race, and posit that in the US in particular, social capital may be distributed along racial lines. We know that Black patients have a disproportionate disease burden, inherently due to institutional and politically driven historical social inequities. And then there's broader environmental factors that come into play. We know that communities have been racially segregated, education, medical systems have been underfunded, and there's discriminatory criminal justice systems, which are all limiting the economic opportunities and potentially social opportunities as well. And so these were things that we were kind of wondering, how would this perhaps play out in the population sample that we have? So our two kind of overarching research questions, I know I gave you a lot of background before even getting to the objectives of the study, but wanted to really show you kind of the work that we did leading up to this. And so our questions were really, how do different forms of social capital relate to health and well-being specific to our population in Southwest rural Georgia? And then to what extent do race and rurality impact how these relationships operate? We felt like we had a really unique sample, again, as a rural population, and so wanted to see, even within a rural population, are there differences in levels of rurality? Excuse me, takes me to our methods and kind of our analytical approach. So this gives you the big picture of what our methods looks like, starting with the descriptives, and then we ran partial correlations on our social capital dimensions to understand, are they truly distinct? Are they related? And then the bulk of the analysis was a univariate analysis of variance, and I'll go into what those four models looked like. And then when we saw significant estimates, then we further ran estimated marginal means to understand for what population groups those gains applied to. So starting off with the descriptives. So this was the demographic characteristics just for the sample who participated in the social capital module. So across the 11 coalitions, 6 counties ended up participating and including the social capital module. And so we have demographics for 1,385 individuals. You can see that the majority of participants are in this age range of 35 to 64 years old. The majority are female, around 66%, and the majority were white, close to 72%. In terms of educational attainment and income, we saw a fairly even distribution kind of across those three categories of income and 4 categories of education, particularly if you added together some high school and high school graduation, those would be pretty similar. And then, as I mentioned, we were particularly interested in rurality. And so we asked individuals, do you live, living in a rural community, do you live in town? Are you in a rural area but have neighbors close by, perhaps a neighborhood? And then are you in a rural area without close neighbors that, there may be miles down the road? And for the most part, the majority, or close to the majority of our sample, were in a rural area with neighbors close by. And then again, as I mentioned, we had 6 counties represented, and this shows you the distribution across those counties. We started out just by stratifying the social capital variables by race and rurality to understand, did they differ by these different groups? And so you can see here that when we look at rurality in particular, there's no real clear patterns by degree of rurality. They're all pretty similar across those means. But then when we take a little bit closer look at race between either Black participants or white participants, we do start to see some distinctions, a little bit differences in the means, particularly here in the diversity of interaction, where for white participants, their mean score was 14, and for Black participants, it was closer to 11. And so we do start to see kind of this difference, perhaps by how the social construct is playing out, depending on an individual's race. And then, excuse me, this takes us to the partial correlations that we ran. And for all these statistics, by the way, we were using SPSS software and set our significance at 0.05. So we wanted to further explore the relationships between these three social capital variables before moving on to more formal analyses. And so the civic engagement was significantly associated with both diversity of interaction and voting behaviors. And you can see the correlation coefficients there with significance less than 0.001. And voting behavior was significantly associated with diversity of interaction. So they're correlated, but you can see those correlation coefficients are pretty low. And so they're still getting at distinct social capital dimensions, even though they are correlated. And then moving on to our more kind of the meat of the paper, the univariate analysis of variance. So we wanted to be able to compare models when we were looking at this with and without blocks of variables. So we looked at things like county and other demographics, and then also included interaction terms. So each of these four models was run on each social capital variable and each health outcome. So that would be a total of about 36 separate analyses. So for model A, we included, again, each social capital variable to see its association with each health outcome and only controlled for county. So just acknowledging the fact that individuals are living in the same county, perhaps some of these constructs are playing out in really similar ways, and we wanted to account for that. And then model B was that same process, but we also included demographic variables. Specifically, we included age, gender, race, educational attainment, and rurality. And I want to note that we use educational attainment instead of income simply because it had less missingness in our sample. And then model C, again, same things, but for model C and D, we included an interaction term. For model C, it was an interaction term between social capital and race. And model D, it was an interaction term between social capital and rurality to understand if there were differences, particularly along those lines. And then following that, again, we looked at estimated marginal means to really help us interpret the significant parameter estimates. And so for this, we conducted a median split and really dichotomized the social capital variables of interest. So you can see for diversity of interaction, we considered low to be a score of less than 14, high was greater than or equal to 14. For civic engagement, it was less than 3 items, high was greater than or equal to 3. Voting was a little bit trickier, only having 3 items total. So we did voting of if they voted in 2 or less recent elections, it was low, and 3 was considered high, and significance was still established at 0.05. And I'll take you through the results. So I'll just go by our social capital predictors. I think that's probably the easiest way to organize it, starting with diversity of interaction. So this is just to kind of orient you to what we have here in our results. On the left, you'll see the different dimensions of health. So overall satisfaction with life, general health status, days of poor physical health status, and then the models going across. DI simply stands for diversity of interaction, and the little asterisks indicate the p-value. So 3 asterisks is less than 0.001 for the significance. So starting with model A, and again, this is where we were just looking at the social capital predictor and the health outcome, and only controlling for county level clustering. So you can see here that diversity of interaction was significantly associated with all 3 health outcomes. And then model B, it was associated again with all 3 health outcomes. This is where we added in those demographic characteristics. And then for model C, we did see that there was a significant interaction between diversity of interaction and race in relationship to overall satisfaction with life. And then again, so we had that significant finding, and then wanted to move on to estimate the marginal means between satisfaction and race. And so here, having greater interaction with diverse social networks was associated with satisfaction of life, particularly among white individuals. And among white individuals, so we can see that there's that higher score in diversity being associated with a higher overall life satisfaction. So if you see kind of moving from one group to another, there's an increase for white individuals. And then looking at this by race, we see that there was a significant interaction between diversity of interaction and rurality for general health status and 30 days of poor physical health status. And so when we dig into that to understand the estimated marginal means, Again, the question is really, so, for whom? For who is this relationship playing out? And we see that those living in rural areas with close neighbors have more interactions with the diverse social network is associated with the greatest increase in general health status. So those living in rural areas with close neighbors having more interactions with the diverse social network was associated with the greatest decline in days of poor physical health. So in that bottom one, we're really looking for the number to go down instead of up, just to kind of track that for you, as compared to those with less diverse social networks. And so we see that this relationship is also existing across these other dimensions of rurality, but it was less prominent. And so it was most prominent, again, those who were rural but had neighbors close by, perhaps in a neighborhood in a rural setting. And then moving on to our findings from civic engagement. So again, model A, we see that there was significant findings across all of those relationships when we were just controlling for county. The same is true when we included the demographics. And then when we added race as a modifier to the relationship between health status and civic engagement, we did find a significant interaction between race and civic engagement. And so, again, with increasing civic engagement, we see that there was an increase in general health status, particularly among white individuals. And while there was a change among Black participants, that change wasn't as strong, which we thought was noteworthy. And then model D is where we look for rurality, and there was no significant interaction term here. And then finally, moving on to voting behavior. Again, we saw that it continued to be significant with all three health outcomes. So pretty consistent findings across these different dimensions of social capital. Same for model B, where we included those demographic characteristics. And then model C, we see that race did modify the relationships between voting behaviors and health outcomes across all of these different domains of health. And so digging into that a little bit more, we see that race modified these relationships between voting behavior and health outcomes, again, particularly strongest for white individuals. So we do see that across two of those dimensions, that there was a positive change between those two areas for Black individuals, but it wasn't as strong. And then finally, moving on to model D, rurality did not seem to play a role here. We did not have significant findings when we looked at how the level of rurality may be moderating this relationship. So kind of stepping back, all the data there, the big question, is social capital positively associated with health and well-being among the rural residents of Southwest Georgia? Yes, kind of largely speaking, we can say yes, we do see significance associating these two categories. There are positive relationships really between these measures of social capital and health and well-being, but in many cases, we saw these relationships did vary by race and rurality. So the health disparities literature, it really does suggest that those living in rural areas are just kind of inherently at increased risk of adverse health outcomes. And we know that within this, there's a more significant burden on African-American rural residents. And so this matters because if we can understand both some of those risk factors, as well as then potentially the complementary resiliency factors associated with health disparities that arise from racialization and residing in rural areas, that can really provide us a foundation for preventing and managing health conditions in these communities. And so while social capital is largely associated with health, again, when we kind of reflected our findings back to the literature, broadly speaking, less work has been done in rural populations than urban populations. Particularly among the three social capital variables that we looked at, we saw that there were having more interactions with diverse social networks, most prominently interacted with rurality. So it was less effective for those, for example, who lived in town in a rural community. And I think this really highlights the complexity of rural communities. Again, often if we're looking at just, a national sample, you have simply just urban and rural, and they're kind of looked at as a monolith. But I think this highlights a little bit of the complexity that maybe we can't look at rural communities in that way. Social capital may be operating as a resource through a diverse network to encourage positive health behaviors. So posit that perhaps those living in relatively more rural communities may have, really less reliance on a formal state, federal system. They may be developing a sense of collective cohesiveness as an individual is just more dependent on some of those informal social networks for their daily life, for their health behaviors. and maybe more likely depend on those communities for their health and well-being, which may result in a greater positive association that we're seeing here between this dimension of social capital and health. And then the positive effects of health we saw were strongest for white participants in our study sample. We did see that there was that sharp increase in general health status with increasing civic engagement among white participants. And Black participants demonstrated kind of a negligible increase in general health status. So there was still an increase, but it really just wasn't quite as large. And voting patterns showed similar patterns across all three health outcomes as well. And so these results, we believe, are indicative of the exclusion of rural Black Americans from civic life and may reflect some of those structural barriers that impact these racialized populations. In general, the literature, when we look back at that on race and racialization, does illustrate the historical and continued exclusion of Black Americans from forms of both social and political capital. So we think of things like voting suppression, gerrymandering, and how lines have been drawn historically and presently, racial segregation, exclusion from the labor market, and that may be particularly present in rural areas. And so Black Americans residing in these rural areas can feel these effects more strongly than their urban counterparts, perhaps because of stark political polarization and lack of political representation, particularly in the American South. So of course, every study has limitations, and I want to acknowledge those. This was a cross-sectional study design, so we cannot assume causality. Of course, it'd be nice if we had it at the start and kind of followed people to say, here's your social capital, what do your health outcomes look like a few years later? But this just really gives us a picture of a moment in time of this population. I also want to acknowledge, as we all know, social capital has so many different ways that you can conceptualize it, whether we're looking at the individual level, social capital that's held for a whole community. And so the level of variables that we chose may have an influence here as well on our findings. And then thirdly, it's a limitation, but also in a way kind of a strength of the study and our intention with it is that our findings are specific to a rural Southwest Georgia population. So it provides a unique glimpse into health and social capital for this community, but we can't really extrapolate these findings to broader communities, particularly those that are not rural and not in the US South. So it provides a little bit more focus here. And so I think kind of broadly, we conducted this study of sort of the gray side of social capital. I talked about, are we just saying that social capital only has positive effects or really has the negative effects? And I think here we see that social capital does have health effects, but who does it work for best, at least in the way that we're conceptualizing it, in the way that we're measuring it presently. And the implications here are that we need to address structural barriers that may limit access to mechanisms of both economic, cultural, social wealth, particularly for marginalized populations. And so I think for our team, we see broadly social capital is having these positive effects on health. They're strongest for white participants. And then as I say with my kids, I tell them I have 3 children. I say I'm learning to become a question doctor, because if I just say doctor, they think I'm going to be a pediatrician. And so I think the fun here is we get to be curious of what next. How do we understand these findings? What questions do we have next coming from it? And so I think there's questions around, are we measuring social capital correctly across cultures? Is it truly that social capital inherently is seen to have more positive health effects for white participants, or is it just that we're not measuring it correctly across different cultures? How do the items specifically perform is kind of another question that we have. If we delve down into some of these specific items within our social capital dimensions, are we going to see variation among those by some of these demographic factors? And then what about other domains of social capital that we haven't looked at? Was there something that would have been more appropriate to look at for this population? And then of course, are there other health outcomes? Is there another way that we could have captured health that would have perhaps shown a stronger association from social capital to a health outcome? So those are the questions that I have, that our research team has, as we're continuing to kind of delve in this area of inquiry. But I really appreciate your attention today, and would love to hear kind of what questions you have, what questions this has prompted as you consider your own work in this area. Thank you.
Great, thanks, Lauren. Fantastic presentation. So we'll have questions and discussion now. So if you have any questions, you can either raise your hand, which you'll find under the reactions tab within Zoom, or you can post something in the chat. And when we get to that question, if you could unmute yourself and ask your question. If you're not in a position to unmute yourself and talk, I'll be happy to read out the question on your behalf, but just indicate this in the chat when you post your question. So perhaps I might start with the first one, Lauren, while we're waiting to see what other questions we have coming up in the chat. And I was particularly interested in the influence, the relationship between diversity of interaction and its influence on people's health actions, because the theory would seem to suggest that diverse interactions aren't necessarily going to have the biggest impact on people's actions, that it's probably more those close-knit interactions, close-knit networks that tend to have the biggest impact on how people's behavior. So I was wondering if
Yeah.
you had seen any of the literature and theory on that that supports the relationship between diverse interactions, which some people may term effectively bridging social capital,
Mhm.
and influence on action.
Yeah, and that was something that we considered, as we were looking at framing the paper and kind of considering the questions that we were including in the sample, was that, yeah, we didn't go the route of bridging and bonding social capital, right? Where you have, your kind of your close network and then your broader network of individuals. And I think the questions that we use don't really neatly fit into either bucket there, right? That we had, it would go back through my slides, but I think that would be scrolling back through like 50 slides. But it wasn't necessarily do you have just a diverse network, but are the people that you're regularly seeing, are they different from you? And so it may be less about the influence of who has influence over your health, and perhaps what we saw here is that if you're not just operating in one little sphere, then maybe you're getting your health information from a variety of sources, a variety of perspectives, and that may be providing more and varied and in this way helpful health information or health services for individuals.
Yeah, because I think that from an applied theory point of view, it seems like it might be a proxy for people's health actions in a indirect way, that the diverse interactions may be indicative of other kinds of characteristics of the individual or behaviors that then also then influence the nature of health actions.
Right,
So
absolutely.
one of the things that sort of stands out in a lot of the social capital literature is that it assumes, say, that when we're asking about interactions, it assumes those interactions are positive. And when it asks about connections, it assumes that those connections are positive. So was there anything in the work that you did or in the literature that you saw that suggested that there might be a way to ask questions that get into that you might be interacting with a diverse range of people, but actually quite a lot of those interactions are actually negative, not positive?
Yeah, it's always a struggle, right? When you're developing a survey, it's like we want to be able to ask all the questions, and it's, who's going to sit down and do our whole entire survey. And so, yeah, I think absolutely, if we had the opportunity, it would be asking, maybe what are some of your perspectives on health, and going into where are you getting health information about this, where are you getting health information about that. And then a lot of the work, it's not, included in this specific paper, but a lot of the work that I do is also qualitative or mixed methods. And so I think that would be an excellent opportunity to say, here's a broad sample that we did. We saw some of these things, and that I would have loved to have the opportunity to kind of delve in with some of these individuals and qualitatively ask, where are you getting health information about, physical activity, how you're selecting your diet, what health screenings you're using. And yeah, where are you getting that information? What are you most influenced by? And I think we would be able to glean more information qualitatively than quantitatively in this instance for sure.
Yeah, no, great. So Jeff, you've got your hand raised. Feel free to unmute yourself and ask your question.
Perfect. Thank you very much. And I appreciate you putting together this presentation. Very much enjoyed it. I'm a part-time adjunct professor in the disaster and emergency management program at Royal Roads. And try to do a significant amount of research into the relationship between trust and information,
Yeah.
and looking at where people turn to sources of information, and how can we correlate that with institutional trust specifically? Because we see a somewhat declining institutional trust pretty much
Mm-hmm.
across all sectors. So I know, and you kind of framed, I think, your answer to my question when you said, I wish I could answer absolutely every question. Obviously, we
Right.
all love to do that at research. Have our respondents sit down. I have 1,000 questions for you. Grab a sandwich. You'll be here a while. But
Yep.
the reality of it is do you think there's worthy, because I'm looking at doing research in a rural part of Ontario, Canada, here where I live,
Mm-hmm.
very similar to what you're talking about here. Do
Yeah.
you think, what's your view on the role of trust and institutional trust and getting that information kind of correlated to what you've said here?
Yeah, yeah, that's interesting to think about. Yeah, I think we, traditionally, at least in the survey that we did when we were looking at trust, it was more, some of it was, more trust in individuals, trust across, diverse social networks. So yeah, I think it could be interesting even to apply, some of our sociological models of health that we use that really look at kind of those concentric circles of going out of, who are you trusting in your inner space? Who are you trusting at your community level, maybe the organizations, and then kind of broader. I think that would be kind of an interesting way to approach that. To kind of think of through, yeah, who are you trusting at what different levels? Who's kind of making those connections? Yeah, I absolutely think that would be a really interesting kind of area of inquiry. And I think some of those models could kind of facilitate that for sure.
Absolutely, because what we find is people will turn to trusted sources in times of emergency. So
Mm-hmm.
depending on who you trust,
Yeah.
will clearly correlated to the type of information that you consume, which is somewhat correlated to the decisions that you make. And so, for example, who trusts the CDC to provide them accurate information? That
Mm-hmm.
will, I think, be indicative when we move this model slightly over to the public health side. You know,
Yeah.
pandemic provided us lots of information as to who and where people turn to for trusted sources of information. And then they enacted on that. And if their trust is not the CDC, they may not be following the model that the government wishes them to do. So no,
Right.
just a general comment. I really appreciate your research.
Yeah.
I love looking at different avenues in that. So thanks for this.
Yeah, for sure. Another question on that. Have you considered social network analysis as a way to approach that?
That's actually the frame that I use. So I do
Okay, great.
mapping of social networks within different sectors and spheres of society. And then I
Mm-hmm.
looking at the relationship of moving information across those trusted pathways. So, for example, the government says preparedness information, most people ignore it. But what if I can
Great.
get the faith actor? What if I can get your trusted community organization, the individuals that you trust, to give you the same information? Our research shows that the likelihood of uptake and behavioral adaptation is greater when it comes from a trusted source. So if you don't
Mm-hmm.
trust the government, maybe I don't need to try to get you to trust the government again. Maybe I just need to put the information across sources of which you already trust. In other words, social network analysis, mapping it, figuring out who's
Yeah.
there, and then using those existing pathways.
Yeah, I'd love to see some of the work that you all are doing. That sounds really interesting. Thanks for sharing.
Thanks, Jeff. Yeah, there's a question in the chat about whether you could share the full text PDF just because it's behind a paywall. I indicated
Yeah,
that for copyright reasons, I certainly couldn't do it, but as the author, perhaps you might be able to.
yeah, I'm happy to. Yeah, if you
What's
want to send me an email, I'm happy to forward that along. Absolutely.
yeah. So Lauren's email is on the screen right now. So anyone who's interested in that, please send Lauren an email. There's another question from Saeed in the chat. They ask, I live in Vancouver and work in healthcare. I wonder if there are similar studies have been conducted in Canada.
Yeah, I'm not sure specifically about Canada. I think when we were kind of broadly looking at social capital and health studies done in rural populations, often they haven't been done in the US. So yeah, I'm not sure specifically about Canada, but I'd be curious about that as well. Of knowing obviously, probably really similar, at least to the US South, where you have these urban centers and then so much of those areas are rural. I could imagine it playing out pretty similarly in that context. Thanks for that question.
Great. So does anybody else have any other questions? Again, feel free to either raise your hand within Zoom or post in the chat. While we're waiting to see, I have another question for you, Lauren. You talked about the relationship between theory and the results that we're getting, and it seems like with a lot of social capital research, the way in which we define social capital suggests that the outcomes will occur. If we're defining social capital as connections and norms and trust, and therefore people spending time interacting, then of course there will be a flow of information resulting from that. It's very difficult to interact with somebody without sharing information at the same time. And so theoretically, we know there's a link there. It's like if we pick up an apple and drop it, we know it's going to fall to the ground. So the theory suggests the outcome, but then the gap seems to be with the research that we do, the way in which we measure a social capital doesn't necessarily capture that. And so
Mhm.
to some extent, and you talked about this as well in your presentation, to some extent, we already know that it's going to happen. We already know there's a link there and a relationship, but the way we do research doesn't necessarily find it in the same way, because ultimately when we're measuring social capital, we're just using proxies such
Mhm.
as diversity of interaction, which doesn't necessarily really capture what social capital is, and therefore we don't necessarily find a relationship, even though theoretically we know a relationship is there by the way in which
Right.
we define the variables. So I guess I haven't really asked the question at all, but interested in your if you have any other thoughts on that and how we might be able to get around that.
Well, I don't. I'll just lead right off. I don't have the grand answer. Wish I did, but I think that's one thing that just intrigues me about this, right? Is how are we defining it? And I think I've seen some interesting work out of Gilbert published a paper recently, again, kind of looking at should there be a social capital, particularly among Black individuals? Are some of their elements of social capital just represented differently in the way in the organizations maybe that they're a part of, the ways that they engage civically? At least particular to the US, may just be different than the way that white individuals engage. And so it could be that we're just missing it in the way that we're capturing it. And so I think, yeah, there is some more work being done in that space of how are we measuring it? How are we conceptualizing it? I think that's some of what our team is hoping to kind of sort out a little bit more. Again, is one of these dimensions really the strong dimension and kind of the key one, particular for this organization or this context? And kind of stepping back, that's kind of broadly what a lot of my work is involved in, is acknowledging that I think so much public health practitioners, social sciences will only say, okay, well, it depends on the context, or that works in your context, but we don't see it here. And so I think it's so important to start kind of defining more of what do we mean when we say context? Are we really thinking about the political institutions? Are we thinking about some of these historical policies that have been in place? Are we thinking in a rural environment simply, is there a train that intersects this county and really changes the way that people engage in their physical environment? Um, and so recognizing, I think that we need to identify, kind of big picture work to be done is identifying some of these contextual pieces to better understand, are there certain measures that really apply to a specific population? And maybe we're just trying to kind of slap that on when it's not getting at the social capital and the way that it's operating in that environment. And so I think that's one of the kind of the frustrating and intriguing things about social capital right now, is that there's so many different ways to conceptualize it. And I think there's a lot of work and a lot of space to further investigate that. And really understand what's specific to a specific environment, what domain might be most salient to a particular health outcome. So lots of questions, not many answers.
Yeah, it's the challenge with the multivariate kind of concepts, isn't it? That there's so many
Absolutely.
different directions for causality, and I guess you talked about that as well, that your study
Yeah.
of course by its nature didn't identify causality.
Right.
um but theoretically it's just as easy or likely for something else to be the causal mechanism that results in the findings that you had than social capital having the causal influence on health. And so
Mm-hmm.
it seems like it's another challenge for us, that identifying causality is quite difficult, particularly if we're doing quantitative research, because it needs to have a temporal factor. But if
Yeah,
we don't
absolutely.
identify causality, then all we have is correlation, and we really don't understand what's going on in a particular context. And I think that's a challenge for all of us.
Yeah, definitely. I think that just points to the need for continuing to develop, test, and refine the theories that we have. I really like that Warnicki model that just, fleshes out all these different points of starting from the individual all the way up to, to the society and the kind of broader environment that we're operating in. But, that arrow between those factors and how that comes is really short. There wasn't a nuance, multiple different pathways there. And so I think there's always this challenge with theory of, and we want something to be able to, test out all these different pathways, but are we making them too complex that we can't operationalize it, or can only operationalize one line of it? And so yeah, I see a lot of work and questions that will be done in that space as well, for sure.
Yeah, because in some ways, a lot of the variation in social capital comes down to individual characteristics. Some
Right.
people, because of personality or whatever reason, may seek out
Mhm.
certain types of interactions very differently than other people. And so when we're doing research that aggregates across large populations, then we lose that. That complexity becomes noise in the data effectively, and it makes analysis much more difficult. But trying to separate that out, it's like Jeff was saying, we'd love to ask a survey that has 1,000 items so that we can really get into that granularity, but no one will ever do a survey that has 1,000 items because it'd take them hours and hours to do it. The challenge, I think, is that because it is so complex and there are so many potential variables, however we end up doing the measurement, again, the measurement seems to be the biggest challenge because we can only ask a certain number of questions, and ultimately they're only ever proxies for what we're really interested in. And the relationship between the proxy and the thing we're interested in isn't necessarily as tight as we'd like it to be. And this is all, I guess, the challenges that we're talking about.
But yeah, I mean, yeah, I hadn't thought about it before, but it would be interesting, even for this, the civic engagement measure that we had, that you could see an extrovert participating in way more of those things than someone who is more reserved. And that's not something that I've seen in social capital measures of what matters to you as an individual, what kind of constitutes engagement with your community. And you could see that really varying perhaps along lines of extroversion, or just different seasons in someone's life and their busyness, that they still may feel extremely connected to their community and kind of in the know, even if they're not able to be or want to be as kind of physically involved in all those different capacities. And I haven't seen that looked at in social capital.
Yeah. Yeah, that's right. Another question just popped up in the chat from Saeed, asking, I'm working on what social capital would look like as a leadership competency, because they're also a leadership coach and advisor. Would you please share what resources would help me learn more about social capital and leadership? Not sure if you have any insights on that.
Yeah, I haven't looked at that specifically, but I think it could be interesting to think about. I think so much of leadership is really coming out of, who is that leader? What is their character? What is the culture that they're able to create in their organization? And so I could see, if you are saying, I want to lead in a way where my organization has close ties, where we trust one another, where we're engaged with one another. I could see those elements around trust and reciprocity being particularly important. And then could kind of be looking back from there of, if I want to have an environment in a community where, a colleague feels comfortable asking another colleague for help, or says, can you bring by dinner for my family tonight? And you want to create that kind of environment. I think those could be points to start with, of looking at, is there trust within our organization? Do we feel like we have these reciprocal ways of operating and caring for one another? And then kind of taking those steps back, maybe looking at some more organizational theories to see how are those kind of cultures created in organizations, and what work could be done kind of from top down. I think that's a really interesting idea.
Yeah, and it certainly seems to be an area of great interest in the social capital literature, is the role of leadership. I think particularly in the context of disaster and emergency management, we see that when an event occurs, the nature of leadership in that moment, in that kind of emergent community, can shape the direction of whether or not people become pro-social and help each other, or they become individualistic and they start looting and taking from each other. And quite often it may just come down to one or two influential individuals that start to shape the nature of the actions within that emergent community. And so clearly leadership plays a very important role in shaping the nature of social capital, particularly in that kind of emergent community, but in any community, of course. An emergent community is something that comes up very quickly, and the direction can be shaped one way or another very strongly. But even in any community, any social grouping, clearly leadership plays an important role.
Yeah, absolutely. Yeah, I think we saw a lot of that. I mean, most of you may be familiar with, the Hurricane Helene that blew through and ended up impacting a lot in Western North Carolina. My family and I, we visited that area a lot, and so are kind of familiar with some of those communities. And I think a lot of the communication that we saw kind of coming out of that, I think points to that there were some who did excellent crisis communication. My background in undergrad was communication of science and technology, so I had some really fun classes on public speaking and crisis communication. And yeah, I think there's absolutely kind of immense opportunities and risks there out of a crisis, of, are you going to be able to communicate in a way where you're forthright, you're honest, you provide that information before people have to ask you for it, where you're able to kind of quickly create that trust and that buy-in for what you're trying to accomplish and trying to communicate. Yeah, absolutely.
So any other questions from the audience? We still have a little bit of time, but get in quick. If you have any other questions, you can either raise your hand or quickly post in the chat. Also interested in any comments that you have as well, or any feedback you have for Lauren about this research. Feel free also to unmute yourself and talk about that as well.
Yeah, I'd love to hear from anyone how maybe you have seen similar results in your work. If you've looked at social capital by individual or community characteristics, and what are some of the things that you found in your work? I'd love to hear that as well.
We'll just give you a minute to ask a question if you can think of one. If you're furiously typing away in the in the chat, I'll just give you another minute. So perhaps one final question from me, Lauren. Just interested in your experience with the concept of social capital. How have you found it? Has it been difficult, frustrating? What's the biggest challenges you've experienced with it?
Yeah, I think just as a young researcher, I'm still in my doctoral program as a candidate currently. It's just a lot of literature to wade through to feel like you really understand the different ways that it's being conceptualized, to understand the history of it. I think particularly since it is such a cross-disciplinary or interdisciplinary concept, I feel like there's just a lot of work to go back and do to really understand, okay, this is coming kind of from this stream of thought, and this one's coming from this stream of thought, and then to figure out how it matches up best with the outcomes of interest again, because I don't think there's necessarily one right way to conceptualize social capital, but that it probably is really dependent on the context, on the population, on the outcome that you're looking at. And so I think that's been kind of the largest challenge for me personally, is I've sought to navigate that and kind of consider it in this broader sense of what are these community contextual factors.
Yeah,
So it's
I think
the
everyone's
challenge and the fun of it.
Yeah, I think everyone struggles with that. It is a huge literature and it is incredibly diverse. And I think that's really the reason why we have the International Social Capital Association is to
Yeah,
help people with that and to provide a platform for people to be
I
able to share
appreciate
their
it.
work. And yeah, I think that's the reason for it. There is a question there from Sonia. Feel free to unmute yourself and ask your
Yeah, go
question
ahead.
or comment.
Thank you. And thank you very much for the presentation. It's very interesting. I have a quick question about in the context of your research, if you looked at in those rural areas, the extent to which there are existing institutions and support services, like community support services, and whether that also then impacts sort of your ability to build social capital. I'm just going to go back on mute here.
Yeah, absolutely. And I think that's something and excuse me, I think a lot of the work that we try to do at the EPRC is not just deficit based, right? We don't want to be looking at a community or a population and say, oh, these are the health struggles, these are the struggles in this way, and try to swoop in as researchers and answer the questions or even ask the right questions. Like, that's not our job. And so I think we have really tried to frame things in an asset based way to say, there's challenges here and you have all these assets, and how can we build upon those existing assets? How can we highlight those? And I think that's something that I have seen in the research and the literature, is that rural areas in particular often have these anchor institutions, which really are functioning as places that are longstanding, they're reliable, they're really providing the source of connection, whether that's a church or a school that's been in the community forever, a community center. That rural communities often have those in ways that urban centers don't, that really do provide this place of collaboration, this place of connection. And so absolutely, I think that is really key to rural communities, and why often their social capital is even higher than it is in urban areas, because they have that need to rely on one another, and they've been able to establish just incredibly rich communities. My grandparents live in rural Ohio, and they've lived there for generations. Their grandparents were also there. And so just that sense of longevity of being in a community, of building up those connections, absolutely, I think that's a huge strength in rural communities, and that urban centers, suburban areas could for sure learn through of creating those third spaces of reliable community connection.
Yeah, it seems to be such an important issue now. We see in so many places those social spaces that are available for community interaction across diverse people from diverse backgrounds, they seem to be disappearing in favor of just corporate spaces, cafes and restaurants and places where you have to spend money, which doesn't necessarily facilitate the kinds of community social interactions that we used to have. And it seems to be a trend that's happening everywhere.
Yeah. There's obviously, broader conversations about, particularly in public health, of social isolation and just feeling alone. And I think social capital can speak so much to that, of really identifying again where is social capital present, where are we really seeing what those connections and how they're flowing, and the physical embodiment of those in communities. I think there's a lot that we can learn from rural areas in that space in particular to address some of those concerns.
So we still have a little bit of time if anyone has any final questions, but we must be getting close to the bottom. So if you do, speak up now, otherwise we'll look to wrap up the session. Okay, looks like we don't have any more questions. So thanks very much, Lauren, for your presentation. We really appreciate it, especially while you've got a head cold. We know how challenging that can be. So we really appreciate you taking the time and effort to present your work.
No, thanks so much for the opportunity. Like I said, it's always fun to kind of come out from behind the desk, come out from the numbers, and be able to share that and collaborate with others. So again, if a question appears to you later, or you just want to chat more offline, please feel free to email me. Happy to pass along our paper and share others of our research. So thanks so much for the opportunity, Tristan, and really enjoyed this conversation.
Great, thanks very much. So our webinar series continues next week. Next week we have a webinar on building social capital. It's actually proving to be incredibly popular. We have about 330 people already registered for that. So it's going to be an exciting one. The details are available on our website if you want to register. And we still have a couple more webinars this year, and looking forward to another big year next year. So I'll stop the recording now. Thanks everyone for taking part. Feel free to stay online a little longer if you want to have a casual chat with anybody before you leave.